Hello friends, let us now learn some important points about the primary immunodeficiency in pediatrics. So primary immunodeficiency in pediatrics, it is divided into five types. It is divided into 5 types. First, primary antibody deficiency. It is divided into primary antibody deficiency, cellular immunodeficiency, combined immunodeficiency, phagocytic cell disorders, and complement deficiencies. Okay, so these are the 5 types of primary immunodeficiencies. Right now, so first we will see in the primary immunodeficiencies. Now if you see, there are 5 types of primary immunodeficiencies, which are X-linked A-gamma globulinemia, combined variable immunodeficiencies, severe IgA deficiency, hyper Igm syndrome, and transient hypogamma globulinemia of infancy. So first we will learn about X-linked A-gamma globulinemia. X-linked A-gamma globulinemia is also called as Bruton's A-gamma globulinemia. It is an X-linked disorder most commonly seen in boys. Here actually what happens here is, here pro and pre B cells, which are the precursors of mature B cells, get converted to mature B cells with the help of the gene BTK gene, and these mature B cells will result in plasma cells which forms immunoglobulins. Now if there is mutation in this BTK gene, then the mature B cells are not formed, there would not be any plasma cells, then no immunoglobulins are formed. So as a result, in the patients with Bruton gamma globulinemia, there is increased risk of lower respiratory tract infections, sepsis, septic arthritis, pneumonia, and osteomyelitis can also occur in these patients. And these patients are susceptible mostly to enterovirus, poliovirus, echovirus, and Coxsackie virus. They are also susceptible to Streptococcus pneumonia, Haemophilus influenza, Streptococcus pyogenes, Pseudomonas, Giardia, and Cryptosporidium. This X-linked A-gamma globulinemia presents at the age of 6 to 18 months of age, and here in these patients we should not give polio live vaccine. If we give polio live vaccine, this will result in paralytic polio in these patients. So in these children we should not give polio vaccine. So if you see, there is no tonsil development because obviously there are no B cells and there is no immunoglobulins. So tonsils are completely absent, adenoids are absent, and if we see, the lymph nodes in these patients are also not palpable, and the B cells, that is CD19 B cells are absent. B cells or CD19 cells are also absent in the peripheral blood. So these are the important points about Bruton A-gamma globulinemia. Now we have combined variable immunodeficiency. Combined variable immunodeficiency is an autosomal recessive disorder which is more common equally in males and females. Here there is defect in conversion of B cells to plasma cells. B cells to plasma cells conversion requires this protein BAFF, but here because of the problem in conversion of B cells to, because of the mutation in BAFF gene mutation, B cells cannot be converted to plasma cells. So as a result, these B cells get accumulated in the germinal centers, and you will also see lymphadenopathy and hepatosplenomegaly, whereas these plasma cells are decreased, and this decrease in plasma cells decreases the immunoglobulin. As a result, this leads to many infections present in the childhood. The child presents early with many infections like lower respiratory tract infections like pneumonia, sinusitis, and this also leads to infections with enterovirus. Giardia infections are also seen. If you see in the peripheral smear, the B cells will increase and plasma cells will decrease. In the peripheral smear, B cells will be normal, but because these increased B cells are accumulated in lymph node and liver and spleen, so in the peripheral smear, if you see, B cells will be normal and plasma cells will be decreased. There is no inducible co-stimulator, that is CD40 ligand is also absent. In these patients, there is impaired responses to both protein and polysaccharide vaccines. So this is about common variable immunodeficiency. Then the third disorder is then the third disorder is Ige syndrome, isolated or selective Ige syndrome. In this Ige syndrome, here there is defect in only Iga. So this patients will mostly be asymptomatic. Sometimes they present with recurrent sinusitis, recurrent respiratory tract infections, urinary tract infections and diarrhea. Sometimes they present with recurrent asthma, and also intestinal giardiasis is also seen. These patients are also associated with sprue-like syndromes, and these sprue-like syndromes may or may not respond to gluten-free diet. And the antibodies to IgA are present here, and because of these antibodies to IgA will result in anaphylactic reactions to the blood products. So these are the important points about selective Iga deficiency. Then the next disorder which is important is hyper Igm syndrome. In hyper Igm syndrome, here this is an X-linked disorder where the defect is in the CD4 ligand defect. Because the most commonly hyper Igm syndrome occurs due to the defect in CD40 ligand. The second most common cause being CD40 receptor defect. So in both these conditions, the class switching is defective. I will just show you the picture, just a minute. It also occurs due to the activation induced deaminase enzyme defect. If there is activation induced deaminase enzyme defect, this results in autosomal recessive condition. So now if you see, this is the B cell, this is the T cell. On the B cell we have CD40 ligand and CD40 only, and on the T cell we have CD40 ligand. This CD40 which is present on the B cells and CD40 ligand which is present on the T cells, both these will interact and cause isotype class switching normally. When it causes isotype class switching, IgM and IgD gets converted to IgG, A and E. But whenever there is defect in either CD40 ligand or CD40, there is no isotype class switching, and this result in increase in IgM and IgD and decrease in IgG, IgA and IgE. Thus there is increased IgM, so this is called as hyper Igm syndrome, right? So what happens in hyper Igm syndrome? So when there is hyper Igm syndrome, if you see the clinical features, because of hyper Igm syndrome, there is recurrent sinopulmonary infections. Why? Because the other immunoglobulins are absent, right? Even though IgM is present, IgA and others are absent. So there is recurrent sinopulmonary infections, especially by encapsulated bacteria is seen. If it occurs by CD40 ligand, here it is X-linked as I have said, and it mainly presents in the infancy. If it is caused by activation induced deaminase deficiency, then this will present in around 2 years of age, and this presentation can also be delayed up to 10 to 20 years of age. This can also be delayed up to 10 to 20 years of age. So now if we see the diagnosis, if you see, there will be decreased IgG IgA and E are decreased, and there will be normal or high IgM is seen. Okay, so you will how are we going to these are the two ways of identifying it, right? Then how are we going to diagnose it? The best method for diagnosing this is flow cytometry. This is the flow cytometric analysis. In the flow cytometric analysis, these cells these are the normal B cells which have CD40 ligand. But here these cells will not have CD40 ligand. When these are deficient or defective for CD40 ligand, then that will cause Igm, hyper Igm syndrome. And we can even identify the mutations also. Okay. Okay, we can even identify the mutations also. These mutations can also be identified. So this is about the hyper Igm syndrome. Then we have last and final type, which is called as Igg subclass deficiency. In Igg subclass deficiency, the normal serum total Igg, there will be normal Igg total Igg will be normal, but there will be decreased in subtypes of Igg. That is the reason why we call it as Igg subclass deficiency. So if we see about this, this is first IgG1. If there is IgG1, this IgG1 shows decreased total IgG levels. If there is IgG1 deficiency, then obviously there will be decreased total IgG levels, because IgG1 is most frequent, is present in higher amounts when compared to IgG2, then IgG3, then IgG4. Deficiency of IgG2 is most common in children. Deficiency of IgG2 is most commonly seen in children, and this is associated with polysaccharide antigens, and this is also associated with IgA deficiency. Then we have whenever there is deficiency of IgG3, this is most common Igg subclass deficiency in adults. And the deficiency of IgG4, these levels vary widely in people, and it is difficult to interpret. So these are the primary in the primary immunodeficiencies, these are the primary antibody deficiencies. Then after this we have one more group which is called as combined immunodeficiencies, right? In combined immunodeficiencies, we can divide the combined immunodeficiencies into 5 types. So in this one, first is we have severe combined immunodeficiency. This also includes hyper Ige syndrome, and this also includes Viscot Aldrich syndrome, Ataxia Telangiectasia, and Ige syndrome. Okay, so first we will see the combined Ig in the combined immunodeficiency. First we will see severe combined immunodeficiency. So right, severe combined immunodeficiency is an X-linked recessive disorder. So it has two parts. One, it can be either X-linked recessive disorder or it can be autosomal recessive disorder. If it occurs due to X-linked recessive disorder, this is due to defect in gamma subunit of cytokines. Normally, this gamma subunit of cytokines will code for interleukin 2, 4, 7 and 12, 15. Gamma subunit of cytokines will code for interleukin 2, 4, 7 and 15, which are responsible for NK cells and T cells production. But whenever there is defect in the gamma subunit of cytokine receptor, these interleukin 2, 4, 7, 15 are defective. Thus there are no NK cells and there are no T cells, right? But B cells will be present in this type. Then we also have autosomal recessive type of severe combined immunodeficiency. Autosomal recessive type of severe combined immunodeficiencies are of three types. One, we have adenosine deaminase deficiency. ADA is adenosine deaminase deficiency. This adenosine, whenever there is adenosine deaminase deficiency, deoxyadenosine will accumulate in our body. This deoxyadenosine is a toxic substance. So B cells, T cells and NK cells are killed by this deoxyadenosine, and as a result here in this type there are no B cells, there are no T cells and there are no NK cells. This type is the most common type of severe combined immunodeficiency. Then we have second type. If you see, second defect. Second defect is JAK3 defect. Okay, this is the first defect, which is ADA deficiency, autosomal recessive. First defect ADA deficiency. Now second defect is JAK3 defect. In this JAK3 defect, here the gamma subunit of cytokine is normal, but there is JAK3 defect. Normally what happens is gamma subunit of cytokines will activate JAK3 receptors, which in turn activates production of interleukin 2, 4, 7, 15, which are responsible for T cells and NK cells production. But now because of the defect in JAK3, the T cells and NK cells are not produced, but B cells are present. So this is second defect in autosomal recessive type. Now if you see third defect in autosomal recessive type, this occurs due to the defect in recombinant activation gene. Normally this recombinant activation gene codes for B cell and T cell receptor, but because of the defect in recombinant activation gene, these B cells and T cells are also defective. Thus there are no B cells, no T cells, but NK cells are present. So these are the different mutations. So if we have to summarize the severe combined immunodeficiency, if it is autosomal recessive type and if it occurs due to adenosine deaminase deficiency, then there is no B cells, no T cells and no NK cells are seen. If this severe combined immunodeficiency occurs due to the X-linked recessive type, and if it occurs due to autosomal recessive type, that is JAK3 mutations, then there will be T cells and NK cells are absent, but B cells are present. If this severe combined immunodeficiency occurs due to RAG1 and 2 mutation, then B cells and T cells are absent, but NK cells are present. So if we see the clinical features, these will present in first few months of life with rash. There will be recurrent diarrhea will be seen. There will be recurrent history of pneumonias in the child. You will also see child suffering from otitis media, sepsis, oral thrush, that is mucocutaneous candidiasis. All these are seen. One important thing which you have to remember here is, if you give any live vaccines to these patients, then this will become a fatal condition. Okay, severe infections will occur. So these live vaccines are actually contraindicated in a patient with severe combined immunodeficiency. This causes infection with bacterial infections like gram-positive bacteria, gram-negative bacteria. It also causes infection with intracellular bacteria like Mycobacterium tuberculosis. It causes infection with viruses like CMV, Epstein-Barr virus. Infections with rotavirus can occur. or respiratory syncytial virus, varicella zoster virus, HSV, herpes simplex virus, measles can occur, or infections with influenza and para-influenza can also occur, and there can also be infections with adenovirus can also occur. So these are the different viral in organisms which can cause infections in severe combined immunodeficiency. Then if you see, even it also causes infections with fungus like Pneumocystis jirovecii and candidiasis. Super infections with candidiasis or cryptococcosis can also occur, right? So how are we going to diagnose this disease? The diagnosis is done, so we will have to suspect severe combined immunodeficiency if the absolute lymphocyte count is found to be less than 2500 per cubic millimeter. If the absolute lymphocyte count is found to be less than 2500 per millimeter cube, then we should suspect severe combined immunodeficiency. If T cell makeup is also less than 20% of total lymphocytes, even then we should suspect. And if maternal T cells are present in the circulation, then these three are the conditions where we suspect the severe combined immunodeficiency. So this severe combined immunodeficiency can be so this can be confirmed by, for confirming it, the best test is to find out the specific gene defect. Okay, specific gene defect is the best confirmation for diagnosis. So this is actually a pediatric emergency if this disease is diagnosed at birth, because if this disease is either diagnosed at birth or if it is diagnosed within first 3 months of life, then more than 95% of the cases can be treated perfectly. So because of that, this is pediatric emergency. Okay, so here in this many therapies have been tried. Actually SCID is the first disease to undergo gene therapy, but this gene therapy this trial is put on hold because many children have started developing leukemias later in the life. So we have stopped this therapy for severe combined immunodeficiency. Nowadays we actually give bone marrow therapy is given to the children, and we can also give if this severe combined immunodeficiency is due to the ADA deficiency, if it is due to ADA deficient SCID, then we can give PEG ADA is also available. So this is about severe combined immunodeficiency. So the next combined immunodeficiency is Igg syndrome. Here there is deficiency of or microdeletion. Actually here there is microdeletion on chromosome 22q11. So this leads to, normally this 22q11 is responsible for TBX1 gene. So here because of this deletion of 22q11, this TBX1 gene is defective. So this TBX1 gene normally causes neural crest cells which are responsible for third and fourth pharyngeal pouch formation, which normally helps in the production of thymus and parathyroid. But because of this TBX1 gene defect, third and fourth pharyngeal pouch formation is defective, so there are no parathyroid and no thymus glands are found. So if we see the clinical features, they can be given by the mnemonic catch. Okay, so first C for cleft lip, this is catch. C for cleft lip and cleft palate, A for abnormal facies, thymus thymic hyperplasia. C for cardiac defects like tetralogy of Fallot. There is H for hypocalcemia, and 22 is deletion 22q11. Diagnosis of this is done by FISH, that is fluorescent in situ hybridization is used for diagnosis of this condition. Then the next disease which is important here is Viscot-Aldrich syndrome. Viscot-Aldrich syndrome is an X-linked disorder which occurs due to the defect in VASP gene. This VASP gene is encoded in chromosome XP11. Here mainly this is 11, okay. Because of this Viscot-Aldrich syndrome, we have a triad, that is recurrent bacterial infections. There will be bleeding causing thrombocytopenia and eczema. So there is prolonged bleeding and bloody diarrhea is also seen in these patients. There will be variable amounts of immunoglobulin is seen, where IgM is found to be low and IgG is found to be normal or low, but IgA is found to be elevated. Treatment of this Viscot-Aldrich syndrome is, here we can give IV immunoglobulin can be used for treatment. And treatment of choice of this condition is bone marrow or cord transplant is the treatment of choice. Okay, transplant should be done. So this is Viscot-Aldrich syndrome. Then the next disorder which we have is, the next disorder we have here is Ataxia Telangiectasia. In Ataxia Telangiectasia, this is ATM gene. Okay, this codes for ATM. Here in Ataxia Telangiectasia, there is defect in ATM gene which is present on chromosome 11q 22 to 23. Right, here because of this defect you will see progressive cerebellar ataxia is seen. Along with that, there is also telangiectasia, that is dilated blood vessels are present in oculocutaneous regions. So this is oculocutaneous telangiectasia are present. This looks something like this. I will just draw a small picture. If you see in the cutaneous form, so if you see in the eye, it looks something like this. There will be some branched arteries or branched blood vessels, tortuous, branched, dilated, many blood vessels can be seen. This is actually oculocutaneous telangiectasia, which is characteristic of Ataxia Telangiectasia. So because of this defect, it can also result in chronic sinopulmonary disease. It can cause chronic sinopulmonary disease, and this Ataxia Telangiectasia will cause increased sensitivity to ionizing radiation, and it also causes defective DNA repair. Okay. Then it is also associated with certain malignancies like lymphoreticular malignancies and also adenocarcinoma. In Ataxia Telangiectasia, we will see presence of low IgA, IgE and IgG2 levels are seen in Ataxia Telangiectasia. Now, the last disorder of this class is hyper IgE syndrome. Okay, in hyper IgE syndrome, it occurs due to the mutation in STAT3 gene. Okay, because of the mutation in STAT3 gene, this is an autosomal dominant disorder where the patient presents with coarse faces and prominent forehead is seen, and there will be the patient will actually look something like this. There will be coarse broad forehead, okay, and there will be wide spaced eyes, there will be broad nasal bridge, and you will also see the facial asymmetry will be there, and you will see hemihypertrophy may also be there for some time, okay. Then if you see the diagnosis, you will have to diagnose it with recurrent skin abscess, and there is increased IgE is seen. IgE is increased, but IgG, A and M are found to be normal, and there is increased eosinophils are seen in the peripheral blood and sputum. This is most commonly associated with infected with staphylococcal aureus infections are common, followed by Candida albicans. Okay, so this is about the Viscot Aldrich, this is about the hyper IgE syndrome. Then after this hyper IgE syndrome, the next group of disorders include phagocyte dysfunction. So whenever there is phagocyte dysfunction, what are the diseases which are involved in phagocyte dysfunction? Phagocyte dysfunction disorders include chronic granulomatous disease and also leukocyte adhesion deficiency. So first we will see chronic granulomatous disease. This chronic granulomatous disease is actually an X-linked disease. This is an X-linked disease which is autosomal and also autosomal recessive disease. Here there is mutation in genes involving NADPH oxidase. So this NADPH oxidase is very important for free radical breakdown. So because of the defect in free radical breakdown, there is recurrent lower respiratory tract infections like pneumonia. Lymphadenitis is seen. Hepatic abscesses are present in liver and other areas. Osteomyelitis is seen at multiple sites, and there is family history of recurrent infections with catalase positive organisms are seen. One hallmark of this chronic granulomatous disease is formation of granulomas is the hallmark. In this disease, the patients are mainly susceptible to catalase positive organisms like Staphylococcus aureus or Serratia or Burkholderia cepaceae, Aspergillosis, Candida albicans, Nocardia and Salmonella. This is also associated with certain disorders like pyloric outlet obstruction. It is associated with pyloric outlet obstruction, or it is associated with bladder outlet obstruction or ureteric obstruction. It is also associated with rectal fistula and intestinal granulomas also, which are stimulating Crohn's disease. So if you see the diagnosis, we do a test which is nitro blue tetrazolium test is done. This is nitro blue tetrazolium test is done. If you do this test, here you will see the you are staining the neutrophils, okay, or macrophages actually. Okay, you are staining the macrophages. So if you see, if this is a macrophage, normally in a normal macrophage, and this is the nucleus of macrophage, when you stain it with nitro blue tetrazolium dye, you will see that there are bluish granules, or you will see presence of some bluish granules, bluish to brownish granules are seen in the cytoplasm. So this is normal. But in a patient with chronic granulomatous disease, you will not see any granules are not seen. So this is characteristic of nitroblue tetrazolium test. Then we can also do flow cytometry, can also be done with the help of dihydrorhodamine assay. Right. The next disease, which is also a phagocyte dysfunction, which is called as leukocyte adhesion deficiency. So this leukocyte adhesion deficiency is divided into two types. We have leukocyte adhesion deficiency 1 and we have leukocyte adhesion deficiency 2. In leukocyte adhesion deficiency 1, here beta 2 integrin family is defective, and in leukocyte adhesion deficiency 2, here the sialyl Lewis X ligand, which is a carbohydrate ligand for selectins, is defective. So here in leukocyte adhesion defect 1, integrins defective. So this causes adhesion of leukocytes to the endothelium, CD11 and CD18 chain. Whereas this leukocyte adhesion deficiency 2 causes defect in cellular margination and rolling. So because of both these, there will be the signs of inflammation are absent and even the pus do not form properly. So how are you going to diagnose it? It's simple. Diagnosis of leukocyte adhesion defect is done by the absence of beta 2 integrins, that is CD11 and CD18 on flow cytometry. By absence of these two, CD11 and CD18 on flow cytometry, we can diagnose this leukocyte adhesion deficiency type 1. Leukocyte adhesion deficiency type 2 can be diagnosed by lack of sialyl Lewis X on neutrophil. Okay, so this is about the leukocyte adhesion deficiency. Now, how are we going to treat these immunodeficiencies? The treatment is done by giving general measures, and we should start the patient on antifungals or antibiotics whenever it is necessary. And we have 4 different types of treatment are available. One, we can give human immunoglobulins can be given. If you see the indications of human immunoglobulin, this includes 1, in antibody deficiency, human immunoglobulins can be given for A gamma globulinemia, common variable immunodeficiency, hyper Igm syndrome, Igg subclass deficiency, and also transient hypogamma globulinemia of infancy. In all these conditions, we can give the human immunoglobulin. And this human immunoglobulin is also given in combined immunodeficiencies, which includes severe combined immunodeficiency, Viscot Aldrich syndrome, Ataxia Telangiectasia. In all these conditions, combined immunodeficiency, human immunoglobulin can be given. Okay, so these are the indications for human immunoglobulins. Then we can give gene therapy also. Gene therapy is available for the following diseases: X-linked severe combined immunodeficiency, ADA deficiency, that is adenosine deaminase deficiency, and gene therapy is also available for genetic variants of CGD and LAD, that is chronic granulomatous disease and leukocyte adhesion disease type 1. Along with this, we have other defects and other things like we can do genetic counseling can be done. and we can also do stem cell transplant, but stem cell transplant is in experimental phase. So this is about all the primary immunodeficiencies. Thank you for watching.